Okay, I'll record to the cloud. And Dr. Auwaerter, thank you so much for your time today.
Thank you, Faith. So we have some questions, and the first one ready to go.
Oh, okay, fantastic. Can you please talk about Indian variants and the vaccine effectiveness, if there is any, to these variants?
Right. So, Faith, I think one of the things that a number of us try to articulate is that when we're speaking of the so-called variants of concern regarding SARS-CoV-2, we don't give it the geographic name and variant. We sort of say the variant first described in India, because to be honest, we have no idea if the variant truly evolved in that particular location. Just so happens that's where the sequencing efforts may have first described it. So the one that probably is most prominent is a B1.617 variant. And the 617 is interesting. We don't know a lot about it yet, but it appears to already account for over 50% of infections in India, it appears, and maybe up to a third of the deaths due to COVID. The WHO earlier in May did label it a variant of concern, the fourth one, so it deserves attention. But at the moment, there's a lot of uncertainty. First, I think it's labeled a variant just because it has appeared in a number of countries, at least 44 by my last count from last week, at least from reports. But whether it's more transmissible or more virulent is still being worked out. So I think we have more experience with some of the other variants of concern, and we'll know more soon. What does appear to be hopeful, though, is at least some preliminary reports about vaccine effectiveness. They're small and preprint studies, but there is a suggestion that people that have had a good response to Pfizer, Moderna, mRNA vaccines for COVID do have their sera does appear to neutralize this variant of concern, first described in India, the 617. So more to come on this, but hopefully another reason to be immunized.
Okay, fantastic. The next question is, do you think that booster immunizations at this point will be required?
So this is a frequent question because everyone wants to know whether you need to, get in line for another shot down the road. I think this will be variable depending on what vaccine you may have had. We do know that some of the traditional inactivated vaccines that are frequently the ones that have been developed in China don't have very long-lived durable responses. The mRNA vaccines are a bit less clear. There are some that think there will definitely need boosters, others not as clear. So the reality, I think, is that only time will tell. And what we'll be looking for are breakthrough infections in people who have been immunized. We do know that at least people that have relatively robust immune responses, that people are protected for at least 6 months. We know that from Moderna vaccines. And of course, as more time passes, we'll be able to assess that further. I don't think there'll be a rush for boosters, gratifyingly. And we also know that at least for the moment, most of the variants of concern, the mRNA vaccines appear to produce sufficient immunity. So far, I think we're benefiting. And one of the reasons you're seeing a declining declining infection rates in some countries, especially Israel, and still largely even in the United States. So I think this is all hopeful, and stay tuned on that one, Faith.
Great, thank you for that. And the next question is, I don't know yet.
Okay,
It's okay. The next
cut that
question
out.
is, no worries. Our next question, Dr. Auwaerter, is how should I encourage parents and their 12-year-old or older students to get vaccinated in a school where it's a struggle to get them the annual flu shot?
Yeah, a perpetual issue for adolescents who are often the least well immunized because they're not getting routine doctor's visits where they may be addressed as to whether they need something like influenza immunization. Uh, I think there is pivoting now in many states from mass immunization sites for getting vaccines into the doctor's offices where they could be administered more routinely. That would be helpful. And if there is vaccine hesitancy, some of the things that I strongly recommend is first discuss immunization with a trusted resource, and I would include your pediatrician. Have your questions answered there. I think there's already strong evidence from initial studies with Pfizer and also Moderna that the vaccines in these age range, excuse me, vaccines in these age range, let me back up. There's already strong evidence, and of course now EUA decision from the FDA for the Pfizer mRNA. Oh my gosh, I'm tongue-tied today.
It's okay. Words are hard. You got this.
Sometimes I'll just start off. The Pfizer mRNA vaccine already has emergency use authorization from the Food and Drug Administration. That's based on initial information that suggests it's very effective. There were no cases in any of the immunized students compared to those who did acquire it if they had placebo shots, and it appeared safe. I think there's little reason not to get it. Talking with your pediatrician, a trusted resource, I would strongly recommend. My neighbor here has a 12-year-old daughter who has been in and out of school because of COVID contacts and need to isolate or quarantine. And I think that's very frustrating for students. The 12-year-old was so looking forward to getting a vaccine so they wouldn't have to worry about isolating or quarantine. So I think the vaccine has lots of attributes for improving lifestyle, also safety within families, because although children tend not to get as seriously ill, they still can. And of course, they could transmit it to family members that may not respond as well to immunization, perhaps the very elderly, perhaps people that have severe health problems or suppressed immune systems. So, much of the rationale here holds for children. I would say one particular frequent question is about fertility. And there's absolutely no compelling evidence that the vaccine at all affects fertility. Indeed, there have already been studies showing no impact on pregnancy. And even in the Pfizer trial, 12 people in the vaccine arm were pregnant and 11 in the placebo. So no sense that the vaccine had influenced the ability to get pregnant or maintain pregnancy. So please don't use that, which is such a frequent issue in many of the social media aspects. That's a complete mistruth about COVID-19 vaccines.
Okay, thank you very much. And the next question. Our next learner asks, for patients with mild or moderate COVID-19, is there any benefit to famotidine?
So Faith, famotidine is a H2 blocker. It's used to help suppress acid in the stomach. And there's been some in vitro and mixed retrospective information to suggest it may be helpful. I think, like many repurposed drugs, I don't hold out high hopes that test tube studies will actually turn out to have clinical benefit. There are prospective trials currently underway. One in a New York health system right now looking at mild outpatient COVID-19 and randomizing whether people take famotidine or not. So I think we'll have better quality information than some of the mixed retrospective information. But for the moment, I would not make any recommendations about using famotidine for COVID-19.
Okay, and the next question is, where can rural residents go for infusion of monoclonal antibody therapy if indicated?
So the monoclonal antibody therapies, which remain investigational but have emergency use authorization, depend in certain states on how they've decided to distribute them. I can give you an example here in Maryland. There are dedicated infusion centers, but certainly where populations are lower, they may not be necessarily nearby. So my usual recommendations are that these drugs do need a physician or healthcare provider referral. And I would familiarize yourself with the nearest referral centers that can evaluate your patient and potentially arrange for a monoclonal antibody infusion. I think they have a tremendous role for patients who may be at high risk for severe COVID or hospitalization. And it would be worth the trip to even spend hours in the car to get the infusion if someone is at high risk. Because the way I look at it, if you live in a rural area and actually become severely ill, trying to get to a healthcare facility may be as difficult as trying to go somewhere for an infusion center. But by all means, look at your state or local health departments under the COVID-19 information, and I'm certain you'll have the information necessary to find out the nearest locations for the monoclonal infusion, which may be in an emergency department, could be at localized health centers specializing in referral or special standalone facilities.
Okay, great. Thank you very much. Another question says, is there a standard accepted definition for quote unquote long COVID?
So Faith, I'm not sure there is yet. The Centers for Disease Control, for example, highlights that a high percentage of people may have symptoms beyond 4 weeks. For example, most post-infectious syndromes, such as after Lyme disease or even infectious mononucleosis, we tend to wait at least 6 months before thinking they truly have a post-infectious fatigue syndrome or something that may be causing a subjective musculoskeletal pain or brain fog or so on. And of course, some people who are ill continue to have respiratory symptoms, cough, easy shortness of breath induced with minimal exertion, and so on and so forth. So I think this will become a little more standardized. We're still coming to grips with some of the post-infectious complications. And no doubt this kind of area does need better development and guidance, and I think this will be forthcoming soon.
Okay, and this question says, do we know who is more susceptible to COVID or how to, I don't know why they use this word, ameliorate
That's it.
risk of long COVID?
Yeah, so
Sorry.
yeah.
Oh, sorry.
I didn't know if
I
you
can,
wanted to say that again or
yeah, I always do a voice. I do my
you do
voiceover
the voice
after.
anywhere, so you cut this out.
I'll
Perfect.
do it one more time though, just for good measure, because I think
Okay.
do we know who is more susceptible to long COVID or how to ameliorate risk of long COVID?
Well, I'll answer the second part. The risk of long COVID is very easy. Go ahead and get a vaccine. Prevention is key here. And I emphasize that especially to younger people who may not think they're at risk for having bad complications of COVID. One study, for example, found that 33% of non-hospitalized people, often younger, didn't return to baseline health within 4 weeks of COVID-19 infection. So, I think there's a lot we still need to understand about this and who's more or less susceptible. Traditionally, a lot of post-infectious syndromes are more common in women, and it tends to be more in women who are under the age of 60. We'll see how some of the studies progress to help define this, but I would just emphasize that immunization is really one of the most important ways, and I think this is really a selling point that's not been as well voiced about immunization to avoid these symptoms that can be very bothersome, long-term, and debilitating for certain people.
Fantastic. This question says, are there any effective treatments besides monoclonal antibodies for patients with mild or moderate COVID?
Faith, so there's been a lot of interest in repurposed drugs, for example, exactly for people with mild to moderate COVID. Monoclonal antibodies, though, remain the only therapy currently under EUA for outpatients. There are a number of clinical trials ongoing, and indeed, at least one trial from Argentina, published in the New England Journal a few months ago, showed that for people over 65, that convalescent plasma of high titer received less than 3 days after onset of symptoms significantly reduced the progression to severe COVID-19. But for the moment, convalescent plasma is not available in the United States, and we're using the monoclonal antibody cocktails. There have been two more phase 2 type trials that have looked at budesonide, which is an inhaled corticosteroid, which appears to be helpful at blunting progression to illness. I think most of us are waiting for a phase 3 trial, but especially in some lower resourced countries such as India, this has been picked up as a potential recommendation for people that have some progressive illness and can't quite get into a hospital and so on. So that's possible. There are oral antivirals currently under study, some of which preliminary information shows some promise, but those are probably months away from us really seeing convincing clinical information. So for the moment, for most people, the emphasis is on either monoclonal antibodies, or if you don't fit criteria that is outlined in the EUA for them, then it's supportive care. Of course, if you become more ill or shortness of breath, heading straight to an emergency department is highly important for evaluation.
Great. Doctor, I don't know why the slide looks like that. It's okay. I'll edit it in post. Dr. Auwaerter, thank you so much for your time today.
Yeah, thank you, Faith, and thank you as always for listening to this presentation.
Okay, fantastic. Matt, you need anything else?